Hi everyone, welcome to the Psychological Resilience broadcasts and thank you for joining us today. As you know, these broadcasts are specifically about looking at the great work that's been done to work with local communities to enhance psychological resilience, to prevent mental health problems from emerging, and to really explore the good work that's being done by a whole range of community partners and statutory partners. In the past, we've explored a lot of local initiatives, but today we've got the opportunity to hear from Somerset Foundation Trust. And I hope that this will have a lot of appeal to a wide audience locally. They are an acute mental health and community and learning disability trust, covering a population across the whole of Somerset of 550,000 people. They are one of the early implementer sites for community mental health transformation and received part of the early implementer monies. And I think that we have many people will be interested in what they have done and the model that they have used. And I hope that you will ask them questions that interest you about how they've achieved what they've achieved. So I think even when Somerset put in their bid for the monies, they weren't aware that we were about to go into a pandemic and couldn't possibly have known what would follow. So I think in terms of what the pandemic has exposed in terms of health and social inequalities and the need to expedite this work to transform the work that goes on in that we do as a mental health provider with our community partners and to think about how we realise the aspirations of the long-term plan in terms of reducing health inequalities. This work will be very interesting to you. So I'm going to start by asking the participants here to introduce themselves to you, and we'll take it from there and we'll wait to hear what your questions are. So first of all, Jane, could you introduce yourself?
Hello, my name's Jane Yeandle and I'm the Service Director for Mental Health and Learning Disabilities in Somerset Foundation Trust.
Thanks, Jane. And Becky?
Hi there, I'm Becky Wardle. I'm Head of Community Services in the South at Rethink Mental Illness. And Rethink Mental Illness are the lead accountable body of an alliance of 9 voluntary sector organisations that are working with Somerset Foundation Trust and the CCG in Somerset.
It's already sounding like an interesting model. Jane, could you tell us a little bit about what you've done in Somerset?
So in Somerset, we, as a result, on the back of the early implementer funding and the 2019 Community Mental Health Service Framework, have developed a model called Open Mental Health, which, as Becky says, is a partnership with the Voluntary Sector Alliance within Somerset, which is essentially a contract between ourselves and Rethink as the accountable organisation and 9 further mental health charities, from those you would expect, such as Mind, right through to some very Somerset specific micro providers. 2 key elements to the model. One is a more of a network or pathway approach where people can come into the service from all sorts of different ways and will be offered specific evidence-based interventions and care and support. The other part of the model is what our experts by experience have named mental health ecosystem, which is very much around building community assets in local primary care networks, local neighbourhoods, villages and towns. And that's about, as I say, being as accessible and open as we can across the community of Somerset.
So thanks for that. I mean, I said a little bit in the introduction about how some of the funding came about, but I just wonder, could you tell us a little bit about why you think you were successful in your application for this bid, and what it is that you bring, and how the funding is conceived of?
So I think we were successful because we very much looked at the kind of community asset neighbourhood element of the model and really embraced the opportunity for partnership working in the voluntary sector. There was a real temptation to think as a foundation trust, who at the time had no primary mental health service to speak of, to look to invest in a kind of traditional primary mental health service. But what we wanted to do and what was transform our offer so that we were working much more in partnership. So a significant proportion of the money came to us from the CCG and then via a contract to Rethink. And some of that is directly paying some of our voluntary sector alliance partners. Another element of the funding is the development of an innovation or grant pot where grassroots organisations can apply in a fairly light touch way to support local mental health and community assets.
So that's really interesting. We talk a lot about asset mapping, don't we? About understanding what's available in our local neighbourhoods. And before I get on to asking you how you do that, I'd just like, could you tell us a little bit about Somerset? Because Somerset is obviously very different from, you know, Lambeth, Southwark, Lewisham and Croydon, the area that we cover. What were some of the challenges in terms of understanding what was available in the local community and how people might access those community assets when they had mental health needs? But what's it like to live in Somerset? Maybe Becky could, or Jane, you were about to start.
It's amazing living in Somerset, but there is very little, very limited transport links. We do have some urban conurbations and areas of deprivation, but equally we can have people living in parts of Somerset where it might be, you know, an hour's drive to the nearest town. So what we had to do, but very often with very limited or poor Wi-Fi connections. So what we've had to do, and in a way that's one of the shaped the model, is make sure that our offer is in people's local towns and local villages, and is resilient to kind of issues in terms of transport and Wi-Fi.
So how have you managed to achieve that, Becky? You are the lead third sector provider organisation, although you have told me before that it's an equal playing field, isn't it? How do you manage to achieve that? You're on mute. Looks like your system's a bit sticky there, Becky. There we go.
Apologies, very sticky system. Sorry about that, but thanks for the question. Yeah, I think it's really important to point out that it is an equal partnership, and again, just as it would have been easy for the trust to invest the transformation funding in the NHS, it would also have been easy, I suppose, to tick the voluntary sector box by just going with one provider like Rethink or the local mind to do all of the voluntary sector part of the work. But actually that would have been really missing the point, I think, of what the community mental health framework sets out, and what can really be achieved by working in this way. So in Somerset, 9 voluntary sector organisations have come together, and at that point when those organisations were coming together to form, to think about what our shared vision, our principles and ways of working would be, Rethink weren't the lead, we were just one of the partners. Then we went through a process of a democratic vote of who would want to be and who would be best placed to be the lead accountable organisation, and that's how Rethink came to be in that position. But a really kind of key part that we maintain is that idea of an equal partnership, with a partnership agreement to underpin that, our terms of reference as a partnership board to underpin that, and a real commitment to being led by the co-production, and also a real commitment that it shouldn't be the big players that are doing all of the delivery. That really isn't the point. And what's really valuable about an alliance and a partnership of this sort is that it allows those smaller grassroots organisations to maybe lean on the infrastructure a bit of the bigger organisations, but to have a place around the table and an equal say.
Can you tell us a little bit more, Becky, about how that works in practice? So I'd be really interested, we've seen during the pandemic, if not before, that, many of these micro organisations are really incredibly vulnerable. Their funding is very vulnerable. And whilst they might want to lean on the infrastructure of larger organisations and indeed of statutory organisations, it's very difficult for those big organisations to be truly responsive to their needs and work at the pace and scale that they do. So how have you made it work?
So in the beginning, I think what was really critical and crucial for the success of the model was to recognise that actually those smaller organisations wouldn't be able to have a seat at the table really in terms of the planning and development of the model unless that was funded and resourced. So in these much smaller organisations, the chief exec who would be attending those meetings also probably does quite a lot of the kind of groundwork and the legwork day to day. So we recognised that and were able to fund out of the transformation funding kind of at the beginning some kind of capacity building around that to allow everybody to be involved on an equal footing. So kind of as time has kind of gone on and we've built that relationship and trust, we've also really developed and identified kind of roles for each organisation where their strengths lie. So for example, Watch, one of our smaller peer focused organisations, which is very kind of grassroots led, is really strong on peer support. So they're leading on that and are able to use their strengths where they have them. So I think it's really about recognising what's needed in order to be able to facilitate people to be around the table, building up that trust so that actually after time when that trust is kind of built up and developed, perhaps it's okay that actually they're not at every meeting because we've built that trust up and that respect kind of between organisations. And again, just identifying what kind of key roles are, being really clear about that, and playing to each other's strengths.
So can you tell us a little bit about what the experience of this partnership is for service users, Jane? Can you tell us how service users approach you and what you think might be different about this model?
So the main mantra that we have running through our model is the term "no wrong door." We made a conscious decision not to go for a single point of access because our experts by experience said that they wanted to access the services in all sorts of different ways. So people can come in, for example, through our 24/7 offer, which is run by Mind. They could go directly to any of the individual voluntary sector organisations, or through their GP, using traditional kind of pathways and introductions. But once they're in the service, we don't have a notion of inclusion and exclusion criteria, or you've come to the wrong place, you need to go back to your GP and get referred to another place. What we say is there will be no wrong door, but if there's someone within the NHS or the Voluntary Sector Alliance who's better placed to meet your needs, we will introduce you to that person and make sure that you're in the right place with the right person. So it's very much a network approach rather than a pathway approach. I hope that makes sense, but
it does. It sounds like people have to be proactive. So there's an onus on anybody who is contacted to do the next introduction if that happens. Not to say, oh, you don't want to come to me, you need to go somewhere else. Have I understood it correctly?
That's absolutely. It's probably put much better than I did, but yes, that's absolutely spot on.
And tell me, because often we do that inadvertently, don't we? We have some kind of telephone triage system or mechanism for identifying where people's needs would best be met, and we don't mean to knock people back, as it were, but we do inadvertently do that. I'm just wondering, is there how have you managed to embed that more sort of inclusive and conversational element?
Well, I think the voluntary sector have been doing this for years, and we play to their strengths. Hence, the main way that the service users come directly into the service is through Mindline, which, as I say, is our 24/7 offer. And the first experience they will have of Mindline is a listening service. So we don't do kind of collecting all sorts of demographic information and doing a triage. That is a listening service, and that conversation, done in a skilled way, does tease out whether a listening experience is all that person needs, or whether or not they need to be introduced to different parts of our model.
And Becky, can you tell me a little bit about how that has been experienced by local communities? So we here talk a lot about building the trust of local communities, about being truly able to engage people. What's your sense of how this is coming across? And then what evidence do you have for your sense of how it's coming across, if you see what I mean?
Sure, yeah, absolutely. So I think the community and the community being part of open mental health is absolutely critical to the model. So I think if we just thought about open mental health as another silo service that we just parachuted in without thinking properly about how that integrates with people's communities and people's lives, then we'd have failed. So people don't live their lives in a box according to a diagnosis, do they? We all know this. They live their lives in communities and want to be able to integrate and access all elements of their community, regardless of what their mental health issues or mental illness kind of may be. So we have a locality model within open mental health, and the voluntary sector part of that locality model is has almost two functions. So it has a client-focused operational function. It also has a strategic function around mapping what we've called the ecosystem, which Jane referred to earlier, and linking with every aspect of the ecosystem. Now, I'm not going to say that we've completely nailed that and got that done. It's early days, but this is kind of what we're working towards, and it's about understanding kind of everything that's in that ecosystem, from social prescribing that might be happening, obviously the PCNs and the GPs that are there, down to a walking group that might happen, or an art club or whatever, and also then identifying what the gaps are. We also have expert by experience leaders roles within all the way through our open mental health system, but crucially for what we're talking about now, we have an expert by experience leader recruited to be part of that strategic function of each locality, and their role is around doing a lot of that engagement, thinking about kind of what the gaps are, and then helping to kind of shape and develop what we might put into place to kind of fill those gaps and make it a joined up system for people. In terms of kind of what evidence that we have at the moment for how that is experienced by people, at the moment most of our evidence, apart from the data that we have so far about the numbers of people that we're reaching, is anecdotal, and we're hearing kind of really great case studies, I suppose, about where it's worked really well, where somebody actually has received support from a recovery and wellbeing worker in their kind of locality, and then that's linked up with a member of Somerset Foundation Trust kind of clinical team to kind of get that support, and it's wrapping around the person. I wonder if Jane might want to talk a bit more about the evaluation that we're going to be doing, which is a kind of work in progress at the moment.
Yes, Jane, perhaps you would tell us a little bit about the evaluation, but also if you could mention a little bit about just, if you think there have been any dangers to this engagement process. So has there been any of the rocky road along the way to engagement? You've made it sound so simple, so straightforward. All you've needed to do is be curious and humble enough to delegate money, and that was sufficient. I'm imagining it was a rockier ride than that.
Absolutely. So if I just talk a little bit about the evaluation first. So we are going to be evaluating and have got a partnership with Plymouth University who are going to help us with that, but they're going to bring much more of a qualitative methodology to that evaluation than perhaps we do sometimes in mental health services. In terms of some of the dangers, we didn't have an altogether positive relationship with all of our voluntary sector colleagues in the past, and they themselves would say that between the 9 of them there was often a bit of rivalry and competition. So without a doubt it's not been straightforward. I think leadership's been really important, and that tone of, you know, we are absolutely in this together. There are some dangers, you know, we have to keep looking at and maintain our focus on that cultural change. You know, this is, you know, asking frontline staff who've been triaging and thinking about eligibility and gatekeeping for the last 20, 30 years of their career to think about openness and accessibility is a big shift. So we cannot understate how that will, you know, that is still a work in progress. Probably the other key risks are around, you know, we're making our service very open and accessible. What if the demand exceeds the capacity that we've got? So we are doing some demand and capacity modelling, working closely with the Commission Support Unit on that. The other risk is probably around primary care network engagement, which is still varied. With some of our primary care network colleagues believing that open mental health means that they will no longer have to see anyone in primary care with a mental health challenge, to other GPs absolutely getting the model. So I can't underestimate enough how important it is to build those local relationships with the PCNs and local GPs so that they get and can buy into the model. So I think demand capacity and PCN engagement, plus the cultural shift that we're doing within all our services and offers, are probably the 3 main risks, but opportunities too.
So we've got a question from the audience around the experience of a service user who might have agreed to be referred to a particular service, only to be finding that they might be passed on to another service, albeit in a gentle way, albeit introduced conversationally. Has that been a risk, that service users thought they would get one thing but they actually get another?
We haven't had that feedback, but we have paid a lot of attention to this model of a introduction, a warm transfer. So you are, you know, absolutely introduced to that person, and we have attended to that quite closely. The other thing that's absolutely got to underpin that is this idea of a trusted assessor, so that, you know, we won't always get it right, but we trust the assessment and we'll learn from those occasions when it doesn't work in the way perhaps it should have done.
So I'm very much getting a sense of values here around curiosity, around warmth, around engagement, around it being conversational, around the feelings of the service user having a priority place here, and that's something that you take seriously in your evaluation of the progress of the service and in the qualitative assessments that the qualitative evaluation that you're doing. Is that correct?
It is, and I think that probably leads me on to another challenge, which is, you know, the invitation from NHS England is to be bold, transformative, innovative. At the same time, you know, we've had to submit reports with about 65 different outcomes and measurements. So it's continuing to have that dialogue with NHS England around, if we really want to engage the VCS Alliance, and in particular some of the very small VCS partners, it has to be recording light. You know, we have to make access and the conversation, the relationship, the key point of what we do, and not collecting, you know, huge amounts of data. And it's a balance that we're continuing to work on.
So that's something also that we've talked about in our organisation, about what we need to stop doing in order to free people up to be able to do some of this work, which you're putting on the front foot now. This relational work, which is about not just relational work with service users, but community assets, that in a way that really engages a full ecosystem. So Beccy, I wanted to ask you a little bit more about the mental health ecosystem approach, and you know, what the crucial elements are of that from your perspective.
Absolutely. So the idea of the ecosystem absolutely came from our co-production with our experts by experience, and I've already touched on it a little bit, but I think in order for an individual to be able to live in their community with moderate to severe mental illness and lead a full life, then having a mental health ecosystem around them that is thriving and full and trauma informed and able to support people to live their lives, not in necessarily specifically mental health focused services, but those and more. So I think that's the key. It's about the whole of a person's community that they live in. And as I said kind of before, it's about that mapping that happens at a very local kind of micro kind of level that our people with lived experience are really kind of leading on and key in to identify what's working well, where there might be gaps, and a really important part of that, which Jane mentioned earlier, is the grants fund that we have that enables, with very minimal bureaucracy and very kind of minimal application system, small peer-led or small micro organisations to be able to apply for a little bit of funding to be able to do something which is going to make a really huge difference. And that's how we're going to be able to kind of prime the ecosystem and help it to thrive. Oh, I think you're on mute.
That's not something a host is supposed to do, is it? I'm supposed to. Can you tell me a little bit about the hidden voices in your system, what you've discovered, possibly even during the pandemic, about who wasn't previously able to come forward and access services, and maybe you've recognised needs that you weren't aware of before in your ecosystem. Is there anything, Becky?
Yeah, absolutely. So I think Jane kind of referenced earlier the rurality, which is, you know, and the digital exclusion, which is definitely something that's come to light. And Somerset Foundation Trust were able to apply for some funding to support that and help those people to be able to kind of access a digital remote access offer. There's a really interesting piece of work that we're starting to do at the moment around an equality impact assessment, and wanting to do that in a much more real way. So often I think an equality impact assessment can become a bit of a tick box, which defeats the object of what you're trying to do. So we're working towards co-producing a system-wide new approach to an equalities impact assessment. So I think there probably will be voices that we haven't heard yet that I hope we will hear through that way of working, and our expert by experience leaders are helping us to develop that. So it'll be exciting to see how that goes.
And Jane, a question for you, which is about how you've managed to maintain this. This is from the audience, that spirit of collaboration and curiosity in the context of, you know, the perhaps the larger public sector rhetoric. How have you managed to overcome some of those barriers when so much of it isn't in your control? How have you managed to be able to be so personal on the front foot when you have had to manage all that bureaucracy behind the scenes?
So I think it is around leadership and you know, and a leadership and operational management team where we've done a lot of work on engagement and our value base and the behaviours that we need to engender in order to really demonstrate that value base, the language that we need to use, moving away from some of the typical NHS language that really drives kind of models towards a much more inclusive model. So I think it is around kind of that leadership and management. It's also around belonging to a larger organisation where there is support for positive risk taking. There is very much a kind of an overarching learning environment. But, you know, without a doubt, I want to be realistic. We do still have, you know, staff who've worked in centres for a long time and who for whom gatekeeping is kind of in their inner fabric. So, you know, it is a work in progress. But I think having a medical, clinical, operational management and leadership that are buying into that model day in, day out is making a big difference.
Can you tell me a little bit, and I know that you're a clinical psychologist by background, Jane, so you know, what's your view about sort of multidisciplinary clinical involvement here? And we started these broadcasts by thinking a little bit about the roles of psychologists and psychotherapists in these transformation agenda. I don't know if that's something you'd be able to comment on.
So a big part of our workforce in open mental health is assistant psychologists, and we're now developing clinical associate psychologists. We do have registered psychologists and nurses, but we're to be quite practical as well around what workforce was available. And what that's meant is that we've got a really bottom-up, grassroots, kind of psychologically informed workforce, you know, who've got that kind of trauma understanding, that are supporting each other and their colleagues. So yeah, I think psychological mindedness has a massive role in strengthening that kind of value base and that we've been referring to.
So we've run out of time now. I could go on asking you questions forever, but you've been absolutely wonderful. Thank you so much for sharing your expertise with us, and it's been a delight. If anybody wants to get in touch with you, I know that you've both left your details in the chat, and they can take them there and follow you either on Twitter or email you directly. But thank you again, Jane and Becky.
Thank you.